Hello, and welcome back to the 2019 LBBC Conference, Sharing Wisdom, Sharing Strength. My name is Haley Dinnerman, and I'm the Executive Director of the Triple Negative Breast Cancer Foundation. Thank you for joining us for this important session, Medical Update on Triple Negative Breast Cancer. This session is being live streamed, so welcome to everyone who's watching from home. Can we give them a round of applause? We're happy to have you with us. Before I introduce our esteemed speaker, I have a few housekeeping items. After Dr. Isakoff's presentation, he will be answering questions. Please put this number in your phone, 610-365-7532. Text your questions to us whenever they come to mind, and they'll be answered by Dr. Isakoff after his official presentation. Yes, it is. That number is 610-365-7532. It will be flashing on the screens at various times as well. And after the conference, you'll be sent electronic evaluation forms. These forms are very important to us, and they help us improve our programming. So thank you in advance for filling them out when you receive them. And now for Dr. Isakoff. So Dr. Isakoff is a clinical investigator and attending physician at the Massachusetts General Hospital Center for Breast Cancer, where he serves as the Associate Director for Breast Cancer Clinical Research. He is an assistant professor of medicine at Harvard Medical School and a member of the NCCN Breast Cancer Guidelines Committee. Dr. Isakoff earned his MD and PhD from the New York University School of Medicine. After completing his residency in internal medicine at the Brigham and Women's Hospital in Boston, he was a clinical fellow in medical oncology at the joint Dana-Farber Cancer Institute, Massachusetts General Hospital Program, and a postdoctorate fellow in the Department of Cell Biology at Harvard Medical School. That is a handful, a mouthful. And so please join me in welcoming Dr. Isakoff.
Thank you. Thank you, Haley, and I want to thank the Living Beyond Breast Cancer Committee for inviting me to speak. I also, if anyone's in the back, I do want to invite you. There's obviously plenty of room, and my eyes are certainly not what they once were, so if you have a hard time seeing the slides, please feel free to move up. Here's some disclosures. So as I was thinking about the talk today, this quote kept coming up in my mind that I thought really characterized a lot of what we've been thinking lately about triple-negative breast cancer. And it was something that I was sure that I heard before, and I scoured the internet to find out who said it so I could give proper attribution, and I could not find anything like it. So maybe it was a quote that I made up. So I put anonymous, maybe I made it up, but I thought it was really apropos for where we are in this disease now. I want to be defined by what I am, not by what I am not. And an example would be, you could say, I am not strong enough, but I think it's more positive to say, I am working hard to get stronger. And you can think of any number of situations where turning the I am not into something more positive with I am. And I think that really characterizes where we are in thinking about this disease now. And so just by way of background, maybe familiar to everyone in this room, but triple-negative breast cancer right now, and for the last 15 or 20 years that we've been calling it that, has really been defined by what it's not, or what it lacks. It's characterized by the lack of expression of the estrogen receptor, the progesterone receptor, and HER2. And I was told that there's a mouse with a pointer, but I'm not sure if that's true. I guess not. And really, it's been a catch-all for breast cancer that does not express these markers. And we use the standard American Society of Clinical Oncology, College of American Pathology definition of ER and PR less than 1% staining. And in the bottom right corner of each panel, you can see a positive control. And we use the HER2 standard definitions. Other key features is that it tends to be a high-grade cancer and tends to have high expression of proliferation markers. We see triple-negative breast cancer in about 20% of invasive breast cancers. We talked about the three markers that give us the name triple-negative. It's seen with a higher incidence in African American and Hispanic patients, as well as younger women, and it's associated with BRCA1 mutation carriers. Despite advances in therapy, we still note that triple-negative breast cancer has a relatively poorer prognosis than the hormone receptor positive or HER2 positive counterparts, something which we're working very hard to change. And it tends to have early recurrences that are more visceral rather than bone, and can often go to the central nervous system. In the future, we're beginning to characterize it in a more molecular fashion, and the details of what's on the left panel are not so important, but basically the point is, if we look at all of the genes expressed in triple-negative breast cancer, and we allow the tumors to sort of self-segregate based on their expression of different genes, we can see that breast tumors will segregate into several different categories. And they've been called, and this is from a seminal paper now over 15 years ago, luminal A, luminal B, HER2 amplified, and basal-like. And it turns out that the basal-like subgroup predominantly was composed of triple-negative breast cancers. And that was really when the bells went off, that this was not just a catch-all where it lacks these three receptors, but maybe this is actually a molecularly defined category. And that's really when the term started to be used, and we started looking into research focusing on this area. And the categories matter. What you can see here in the red line are the outcomes from early studies, not that many patients, but just showing that in the basal-like group, the outcomes were poorer than for the luminal A and luminal B groups. At the time this study was done, the anti-HER2 drugs were not yet in full force, and so HER2 also had a poor outcome. But we've come to understand that triple-negative breast cancer is really a heterogeneous group, really diverse. It has diverse characteristics. And so what's shown in this slide is just showing that if you look at triple-negative breast cancer and you then categorize it into those different molecular subgroups, the majority is that basal-like subgroup, but it's not 100%. And you can see that there's actually a fraction of molecularly HER2-like, luminal-like. And then, in addition, if you look at other ways of molecularly characterizing this, and this is from a group at Vanderbilt, came up with a different way to categorize this molecularly. And there's at least 6 different subtypes. And they carry names like mesenchymal, immunomodulatory, basal-like 1 and 2. And the point being that we're beginning to understand different ways of molecularly characterizing what traditionally was called triple-negative breast cancer. And the pie charts on the bottom are just to bring out the point that the two groups, the two different categories or systems of molecularly characterizing these don't 100% overlap either. And so these are probably really different. So given that it's heterogeneous, I think what we've all been trying to do in the last decade and a half is figure out how can we turn a negative into a positive, and how can we begin to define subgroups of triple-negative breast cancer beyond just lacking those 3 markers, but instead, what are some of the characteristics it has that might lend itself to improve treatment options? And so for the next chunk of time, probably the majority of my talk, we're going to talk about immunotherapy-sensitive triple-negative breast cancer and some approaches there. I think one can't give a talk, certainly in breast cancer, but particularly triple-negative breast cancer now, without talking about immunotherapy. It's been in the news quite a lot, and it's certainly one of the most hot areas of research. And so I'll devote most of my time to that and then talk about a couple of these other categories. So as a background, just given a general audience, I want to make sure we understand what immunotherapy is. So the first few slides are just an introduction. Immunotherapy was first described actually in 1891 by William Coley, who basically found that in patients who had certain skin infections would develop a remission to a sarcoma that they had. And he developed these Coley toxins, which are actually inactivated pieces of bacteria, either Streptococcus or Serratia. And he injected some patients with these bacterial fragments and actually noticed that there were responses, particularly in sarcoma. And this was used for much of the early 20th century, but by 1962 it fell out of favor, and eventually the FDA declared it illegal to use these, and it was immunotherapy was kind of quiet for a while. When we talk about immunotherapy, what we're really talking about is a therapeutic approach that harnesses your own body's natural defense system, the immune system, to recognize and treat cancer. And the immune system is made up of a number of cells, which I've just outlined here in a very basic cartoon form. The key ones that we'll talk about today really are the T cells in the green, the cytotoxic T cells. And so if we think about how can we activate the immune system to seek and destroy cancer, there's sort of an analogy I made. So if you're sitting in the car and you want to try and get to cancer cell death valley, there's a couple ways that you can get there faster. One is you can step on the gas pedal and make the car go faster by accelerating. And the other is by taking your foot off the brakes and releasing the brakes and allowing the car to then proceed. And I think this is a reasonable analogy about how we think about some of the most common approaches in immunotherapy. You can also make a more powerful, faster car. And I'm not going to speak much about this approach right now, but this is really where the CAR T cell area has been exploding, if you've seen that. And so the analogy here is that the stop sign, or the releasing your feet off the brakes, is really the area of checkpoint inhibitors. Helping the car go faster or recognizing the cancer is where vaccines come in. And then, as I mentioned, making the car itself go faster by getting a better car is the chimeric antigen receptor T cells. And the bottom one I'm not going to speak about further today. So the promise of immunotherapy is that it's really given us a paradigm shift in the treatment of cancer by using your own immune system to target cancer. And the idea is, instead of a drug that you take, it's really a living drug, and it can allow for the potential for long-term responses. In addition, in most cases, it has very low toxicity, but there are significant limitations, and in some cases, it can have actually quite severe toxicity. And in a way, it's a smart strategy to overcome the molecular complexity of cancer. It's not one drug hitting one target, but it's allowing your immune system to intelligently adapt to the cancer. And so I want to spend the next chunk of time, as I mentioned, talking about checkpoint inhibitors for triple-negative breast cancer, where we've seen the most excitement so far. So this cartoon is just to kind of give an idea in a little bit more detail about how checkpoint inhibitors work. And I'm sorry I don't have the pointer available, but on the left side in the green is what's called an antigen-presenting cell. And the job of that cell is to scour the body looking for invaders. And so, for example, if it eats up a piece of a bacteria, it will chew it up, and it will then present it to the blue cell there, which is that cytotoxic T lymphocyte. And on the blown-up panel just below that, you can see that in red is that little bit of chewed up piece of bacteria or other material that's being presented to the T cell, and that stimulates the T cell to now recognize that. But you want to make sure that the T cell doesn't go and fight normal cells in your own body. And so there's an inhibitory pathway, and that's shown in the bottom there, that molecule labeled CTLA4. And the only point of this is to say that we now have drugs, antibodies, that block that molecule CTLA4 to allow that T cell to get activated. When the T cell is activated, it enters into the bloodstream shown in the middle, and then it can deposit itself, for example, in a tumor. But in many cases, it won't attack the tumor, and we now understand a little bit more why not. If you look at the bottom expanded panel, you'll see in the yellow, there's two molecules on the left side called PD-1 and on the right side PD-L1. And those two molecules essentially form a handshake, which is the tumor cell's way of telling the T cell, don't attack me, I'm one of you guys. But now we have antibodies shown there that can block that interaction and essentially break that handshake to now allow the T cell to attack the tumor cell. And based on these discoveries, the Nobel Prize last year was awarded to Dr. Hanjo and Dr. Allison for their discovery of CTLA4 and PD-1. And I think this is now well known in the popular press. And we've actually seen a lot of checkpoint inhibitors approved, and you can see a lot of diseases have actually several drugs approved. In breast cancer, we finally, and I'll talk a little bit more detail, have a drug approved shown in the middle, atezolizumab, and it's likely based on some phase 3 studies that should be presented soon that we may see an additional checkpoint inhibitor approved. So another point that I want to make about immunotherapy for breast cancer is tumors can often have what we call a high burden of genetic mutations or a high tumor mutational burden. which essentially means more mutations have built up in that tumor cell. And what that does is it may cause the tumor cell to then release more abnormal proteins that are not normally seen in that tumor cell. And that may attract more T cells to that tumor, T cells that we call tumor-infiltrating lymphocytes. And that, in a way, may make the tumor look more foreign to the T cell than self. High tumor-infiltrating lymphocytes correlate with a higher chance of responding to checkpoint inhibitors. And various types of cancers, and in particular triple-negative breast cancer, tends to have higher rates of tumor mutational burden and higher tumor-infiltrating lymphocytes, making it a good target for checkpoint inhibitors. And this is just an example showing you the amount of diversity of tumor mutational burden. And on the right side, which is in small print but circled, are diseases like melanoma and lung cancer that have high tumor mutational burden, where immunotherapy first was approved. And in the middle is where you see breast cancer, and you see that it's a pretty broad range. This is a logarithmic scale, which means small changes up or down are actually log-fold changes. But here, breast cancer is all lumped together, and in fact, the triple-negative breast cancers tend to be at the higher range of this spectrum. And so originally, we looked at monotherapy or single-agent checkpoint inhibitors for triple-negative breast cancer. And we saw that there was some activity, and so summarized here are just the response rates to a few different single-agent drugs. And you can see that it ranges somewhere in the 5 to 23% range for single-agent activity. It's not certainly as good as we want, but I think this was very promising that we were working with something that might be active. And one of those drugs, Pembrolizumab, is shown on the right, and then atezolizumab is shown on the left. And it turns out that when you give the immunotherapy in the course of advanced disease does matter. And so on the left of each color is the first-line treatment. And you can see when these drugs are used as monotherapy in the first line, we actually see reasonable response rates in about the 25% range. But if it's used beyond second line, it's much lower. And so that tells us that getting immunotherapy up there earlier is probably going to be better. And the response actually matters. What's shown here is the outcomes of patients who either had a response, on the left side shown in green, who had stable disease, shown in blue, or who never responded and had progressive disease right from the outset. And you can see, for example, that in patients who did have a response, they actually responded and did well for quite some time. And the same was true with Pembrolizumab, shown on the right panel. But I think really where the field is moving is more towards thinking about combinations of checkpoint inhibitors with chemotherapy. I think we've realized that single agents are not going to be the answer, and we need to combine this. And many people have always thought that chemotherapy isn't that an immunosuppressive agent. We're all familiar with the risk of infections, and so wouldn't it potentially inhibit the immune system from fighting cancer? And actually, the truth is, it doesn't seem to, and in fact, it may actually help sensitize both the immune system and your normal body to be able to respond to immunotherapy. And so it turns out it's actually both pretty safe and adds to the activity. And so the study that sort of really now put this on the map was called the IMpassion130 study. This was a randomized phase 3 study in patients with triple-negative breast cancer who were receiving either first-line therapy in the metastatic disease, who either never had any prior chemotherapy for early disease, or if they did, it was greater than 1 year ago. And patients were randomized to receive nanoparticle albumin-bound paclitaxel or Abraxane with or without one of the checkpoint inhibitors, this one called atezolizumab. And patients were followed, and the primary endpoint was what we call progression-free survival, and a co-primary endpoint of overall survival with a bunch of additional secondary endpoints. And what you can see here on the left side in terms of overall survival and progression-free survival, if you looked at all comers, there really wasn't much change. I don't think it takes a big imagination to say that the blue line and the red line are not too different. But if you look at the population that had that marker that I mentioned before, PD-L1, which is that secret handshake marker, if you look at the tumors that had that expressed on the immune cells, which made up about 40% of the population in this trial, you began to see some, okay, I'm not sure that will help. You'll begin to see some evidence of a response, and you can see a difference here in the overall survival, and if you can read those numbers, it actually, a median overall survival went from 15 to 25 months. Not a home run, but that's really far better than we typically see for anybody who's familiar with many of the drugs in clinical trials. That's a pretty dramatic improvement. And so that was published in the New England Journal and made all of the lay press as a really very exciting result. And based on that, in just March of this year, we now had our first FDA approval for an immunotherapy in triple-negative breast cancer, limited to those patients, which again makes up about 40%, who have that PD-L1 marker on their immune cells. And so this was very exciting. This has now become standard of care. Routinely now, our patients with triple-negative breast cancer are getting tested for PD-L1 with advanced disease, and we are using this routinely. Interestingly, although the trial, as I mentioned, required that you were either first line and had been more than 12 months from your early stage treatment, the FDA label actually did not limit it to first line. And so this is something that we're testing and using for patients who have never seen an immunotherapy drug before. As I mentioned, most patients have no side effects at all. It doesn't cause hair loss, it doesn't cause nausea, it doesn't really cause your blood counts to go down. However, a portion of patients can have very severe toxicity because by activating your immune system, you can trigger your immune system to recognize your own body's normal cells. And so basically, the way when I'm talking to patients, I explain the potential toxicities is I just say basically any itis is something you can get. Any inflammation against any of your own body parts. And that could be pneumonitis for the lungs, hepatitis, nephritis, really just across the board. Some of the most common ones that we see are colitis causing severe diarrhea. Fortunately, these are all relatively uncommon, but common enough that we do see them. And in fact, at our hospital and at increasing numbers of hospitals around the country, if a patient is on one of these drugs and comes in with a presumed toxicity, we actually have a separate inpatient service just to take care of these patients because it takes some level of expertise. And without aggressive early management, the side effects can be potentially life-threatening. And this is just showing you the toxicity table from that IMpassion130 study. And the only point here is in bold, I highlighted hypothyroidism or low thyroid was significantly higher in the immunotherapy arm, as well as rash. But fortunately, the high-grade toxicities, which are in the grade 3 to 4 column, the right side of each color, was actually still fairly low. But some toxicities in these areas were fairly common. So this was all with paclitaxel. Do these results apply to other chemotherapy combinations? So there's a trial that has been looking at this called the TONIC Trial, and this was basically taking an immunotherapy drug and combining it with a variety of different chemotherapies, and in fact also was combining this with radiation. And in this particular study, they showed that doxorubicin or adriamycin, shown in the blue, seemed to have the highest response rate. There are multiple combinations, dozens if not hundreds in breast cancer alone, looking at different chemotherapies with immunotherapy. And I think really the answer to this question is still not known, but it is highly likely that there will in fact be differences. And this may have to do with how immunosuppressive certain chemotherapy is to the normal immune system versus to the normal host. But there's still a lot more work to be done in this area. And then there's also a question, as I mentioned, that trial looked really at first-line patients, but would we have seen any benefit in patients who recur in less than 12 months from when they finish their early therapy? Certainly that makes up a large proportion of the patients that I see in clinic are patients who I treated and unfortunately have a recurrence relatively quickly. And so there's another study called the IMpassion132, which is now looking at patients who did recur in less than 12 months. And specifically in that population, they're randomizing to either gemcitabine plus carboplatin, or by investigator choice, you could use capecitabine. But then patients are randomized to also receive either the atezolizumab or placebo. And the results of this study has been completed. The results we're all waiting for. Hopefully at an upcoming meeting we'll see this. In addition, we're also now very interested in looking at checkpoint inhibitor immunotherapy for early stage breast cancer. As is typical in the course of drug development, when we see promising activity in the advanced setting, the next thing to think about is, can we bring that drug into the early stage, and now can we either increase cure rates or increase patient benefit in the early stage. We know from many studies now, and this is just a figure taken from my colleague at Mass General, Laura Spring's paper, that if you can have complete response to your preoperative chemotherapy, meaning if you get chemotherapy before surgery and all of the cancer disappears such that at the time of surgery there's none left, we know that that correlates with a much better prognosis than if there is significant amount of disease left when you have surgery. And so this has become somewhat of a model or a paradigm for drug development to see if we can improve the rate of complete response in the preoperative setting. And so one of the first studies to report out on this was a study called the I-SPY study. This was a multi-institutional collaborative study where there were actually multiple arms, and I'm not showing them. It's a very complicated statistical design. But basically, everybody starts off as the control group getting the backbone of standard adriamycin, Cytoxan, and Taxol, but the order is flipped. So everybody is going to get Taxol followed by AC. And then you sort of plug and play different novel drugs into this in a very easy fashion, so you can quickly assess whether a new drug is helping. And so this was done with Pembrolizumab, one of the checkpoint inhibitors. And what they showed that you can see in the red box is and there's an odd statistical design, so suffice it to say that the predicted complete response rate improved from 20% to 60% with the addition of Pembrolizumab to the standard ACT backbone that many of us are familiar with. Based on the statistical design, that had a greater than 99% probability of predicting success in a larger, more traditional phase 3 trial. And in fact, that trial has now been completed. That's called the Keynote 522 study. That study enrolled over 850 patients, and they were randomized to receive Pembrolizumab or placebo with Taxol. And in this study, they actually added the carboplatin as well, so it's actually 4 chemotherapies. Everybody gets paclitaxel, carboplatin, then AC, with or without the immunotherapy, and then they go to surgery, and the primary endpoint is complete response. There's a similar study, the IMpassion130, which is looking at the atezolizumab drug with paclitaxel followed by AC and then surgery. And then there's also the IMpassion130 study, which is looking at using immunotherapy in the adjuvant setting, which means after surgery. Now, we should see results of this actually just in about a week of the Keynote 522 study at the ESMO meeting in Barcelona. But Merck has put out a press release over the summer saying that the study did meet its primary endpoint and is a positive study. And so that's why in the table I had the parentheses around the Pembrolizumab. It is likely that they will try and get an approval. It will be interesting to see if the FDA will grant approval just based on this result, or if they're going to want to wait to see a little bit more long term to confirm that patients actually do better in the long run. But this is very exciting, and it is likely that in 1 or 2 years from now we will be routinely considering immunotherapy in the early stage setting. And then just a couple words about novel combinations of the future. Can we use other combinations with targeted therapy to enhance the activity of immunotherapy in triple-negative breast cancer? Not going to go into very much detail, but PARP inhibitors, many of you may be familiar with, are a drug that are currently approved for BRCA1 or 2 mutated breast cancer. And they are being looked at, as well as many other drugs, in combination with immunotherapy. And so on the left panel, what's supposed to be indicated by the thermometer showing cold is what we call a cold tumor, which is it does not have a lot of those tumor-infiltrating lymphocytes. The immune system does not seem to be active in that tumor. And the goal is really, how can we turn that tumor into a hot tumor? How can we get that tumor to have the immune system flood it and then be more susceptible to immunotherapy? And one of the hypotheses was that combining immunotherapies with a PARP inhibitor may actually help that to happen. And so there was a study presented less than a year ago at our San Antonio meeting called the TOPACIO study that was looking at exactly that combination. It was looking at Pembrolizumab, which we were just talking about, with a particular PARP inhibitor called niraparib, looking at the overall response rate. And they enrolled 55 patients, and 19 patients had clinical benefit. Half of them had BRCA mutations, and so likely would have gotten benefit just from the niraparib, but the others didn't, and this combination seems to have some appeal to look further. And there are a number of other studies looking at similar combinations, and so we'll have a lot more data about this in the future. And there are innumerable combinations ongoing. I'm going to talk in a bit about PI3 kinase inhibitors, not with immunotherapy combinations. Well, actually, I will. But everolimus, a bunch of other targeted therapies that are being looked at, all very early. None really have reported out in anything more than phase 1 studies. But suffice it to say that it's a very active area of interest to see what we can intelligently combine immunotherapy with to get better activity. And I just want to point out, this is taken from Dr. Allison's Nobel Prize lecture, where he was sort of trying to convey the optimism for immunotherapy. And so with most drug development in the past, we would typically see a relatively small shift in improvement from the red line to the blue line with the addition of adding a new drug. Modest, but some benefit. With immunotherapy, we've started to see some patients at the tail of the curve who are actually doing well for a very long time, and this has been very exciting. But what we really want to do with these combinatorial approaches is figure out how can we get more patients into that long-term benefit range. And I think this is really the promise of immunotherapy in triple-negative breast cancer that we're all hoping for. Just a few slides on cancer vaccines. This was sort of the corollary to stepping on the gas pedal. Cancer vaccines are designed to do a few things. Number one, they stimulate the immune system to recognize and attack the cancer cells specifically without destroying or recognizing normal cells. They target what's called tumor-associated antigens, which are basically proteins that are new in the tumor that are not found in the normal rest of the body. And they elicit these tumor-specific immune responses, and because they're T cells, they have a memory function and they can induce long recognition. And they can generate innumerable, immune and clinical response that we hope will then impact survival. And so vaccines shown in this cartoon can be fairly straightforward conceptually to think about how they're made. Basically, you can take out a piece of a tumor. You can break up that tumor and the proteins in that tumor into small fragments called peptides that are found in the tumor that may not be found in the rest of the body. You can then pull out those peptides, or you can pretty easily artificially synthesize them in the lab. You can then inject those peptides back into the patient's body, and then the immune system will recognize those peptides and can be trained, in a sense, to then go and try and find them in the cancer. The vaccines or peptides can be either generic, meaning they're taken from, let's say, triple-negative breast cancer and should work across all of triple-negative breast cancer, or they can actually be personalized. You can have individual personalized vaccines where a patient's own tumor is broken up and turned into a vaccine, and it can be very personalized because each patient will have a different milieu of that protein mixture. And so one example of this was presented recently called Nuvax. Now, many of you may be familiar with the HER2 protein. We talked about it as one of the 3 markers in breast cancer that triple-negative breast cancer generally doesn't have overexpressed. But almost all cells in our body have some amount of HER2. And so what this group did was they generated a vaccine against a piece of HER2. And they specifically wanted to look at patients who did not have high-expressing HER2, which would be HER2-positive breast cancer, but actually look at patients who had low-level, which are the majority of the rest of the patients. And so they enrolled 275 patients who had HER2 low expression, and the original data set included triple-negative and hormone-positive patients. And they were patients who completed all of their treatment for early-stage breast cancer. And they were then randomized to receive the vaccine or a placebo. And this was presented earlier this year. And what they showed, which you can see here, is that the patients, this is now looking at the triple-negative subset, when you look at 2 years to see the number of patients who've had a recurrence of their cancer, you can see that in the blue line, the patients who received the vaccine actually did significantly better than the patients in the red line who received the placebo. And I think this was very encouraging that there may be some signs of activity here that would be encouraging to now go look at a much larger study. There's currently 2 ongoing vaccine studies that I just wanted to mention briefly that we have going on. One is for early stage triple negative breast cancer using a vaccine against an entity called the folate receptor alpha. This is a study that's being led by the Mayo Clinic, looking at 280 patients with early stage triple negative breast cancer, all of whom will have completed their regular chemotherapy within the last year. They're randomized to receive placebo or this vaccine. And we have about 60 to 80 patients enrolled so far. We're hoping to enroll over the next 2 years. And again, look and see if we can see a reduction in the number of patients who have a recurrence. And then we also have a study looking in metastatic triple negative breast cancer, a pilot study in 20 patients. Regardless of how many prior treatments they've had, you can even have had prior immunotherapy before. And patients receive a vaccine called PVX, which is actually 4 peptides, 4 of those little protein pieces that are found in triple negative breast cancer. And we're giving that once a week for 6 weeks, and we're combining it with Pembrolizumab, one of those checkpoint inhibitors. And we're looking for signs of immune response. So did your body make a reaction to that vaccine? And then also looking to see how many people respond. And so that study's ongoing. So now I want to jump, and the last part of the talk will be shorter than the first part, obviously. But I want to jump to some other targets that have really been quite interesting in triple negative breast cancer lately, hopefully leading to some approval soon. So there's a new class of drugs called antibody drug conjugates. And what these drugs are really quite clever. You start off with a monoclonal antibody, which is shown in the blue. But the job of this antibody is to really serve as sort of a homing beacon. And attached to this antibody in yellow is a linker, and then attached to that linker is a drug. That drug then, by being attached to the antibody, can be dragged directly to the tumor cell, and so the chemotherapy should not have as much toxic effects throughout the rest of the body. And you can use much more toxic chemotherapy agents when they're linked like this than you might be able to give someone in the normal intravenous fashion. And so the drug that's furthest along is called sacituzumab, or IMI-132, and this is an antibody against a protein called TROP2. TROP2 exists on most triple-negative breast cancers, and in fact on many epithelial cancers. The function of TROP2 is not known. It's not thought to be a pathologic piece of a tumor, but it serves as a nice marker for the antibody to come. It has a linker, and then it has a payload called SN38, which is a derivative of irinotecan, which is a standard chemotherapy. And you can attach about 7 of these molecules, chemotherapy molecules, to the antibody. And what you can see on the left here is when we looked at a population of triple-negative breast cancer patients, all of whom had had a lot of prior chemotherapy, at least 2 lines or more, you could see that there was the majority of patients had some shrinkage of their tumor. 34% met the criteria for what we call a partial response, and about 45% had clinical benefit. And the median progression-free survival was about 5.5 months. We normally expect in this kind of population, the progression-free survival for most drugs is in the order of 3 months. And so this was an encouraging sign. There was toxicity associated with this, less than it would have been had we given the drug free. But we did see a fair amount of neutropenia, or low white blood cell count, and there was some diarrhea associated with it, although we got much better at managing that. It also, unfortunately, does still cause hair loss and does cause some nausea that was relatively easily managed. And so based on that initial study, we've now completed a large randomized phase 3 study where we've taken triple-negative metastatic breast cancer, and patients have had to have had at least 2 lines of prior therapy and we're randomized to either IMI-132 or treatment of physician's choice from one of those 4 chemotherapies that are all standard chemotherapies. Enrollment has been completed. We're waiting for the final results. This drug did go up for early accelerated approval and was held up because of some manufacturing issues, but we are very optimistic that after the new year this drug will be approved, and then if this study turns out to be positive, it will go from accelerated approval to a full approval. That's certainly our hope. There are many ongoing studies now looking at this drug in combination with other drugs. So in the early stage setting, we're looking at it compared to Taxol, replacing the Taxol as part of the standard regimen. And in the advanced setting, we're combining it with immunotherapies and with with PARP inhibitors as well. There's another antibody that's showing some promise, which is against HER3. So HER3 is a cousin of HER2. It's in the same family. It's also present on many cells. Another company made a drug where they linked a different version of irinotecan called exatecan to this antibody. And now they're looking at triple-negative breast cancer patients that have high levels of HER3, which is about 30% of the population. And what you can see here, basically, if you look at the lines going down, that's just showing how much shrinkage there's been of the tumor across a number of patients. And in blue are the triple-negative patients. And you can see that this drug in the high HER3 patients seems to have pretty reasonable activity. And so there's ongoing studies looking at this drug now. And so the last area that I was just going to touch on relatively briefly is the PI3 kinase pathway. This is another pathway that's altered in a percentage of triple-negative breast cancer. And so the cartoon on the left is just showing the PI3 kinase pathway in cells. And really what this pathway is a critical pathway to help control cell growth and cell division and nutritional and metabolic support for the cell. And a classic example is the insulin receptor, is a receptor that sits on the surface of all of our cells. And when insulin binds, it triggers a pathway inside the cell where a molecule called PI3 kinase gets activated, and that sets off a cascade of signaling where another molecule called AKT gets activated, and eventually that signals to the nucleus to tell a cell to grow and divide. It turns out that this pathway is altered in about 40% of triple-negative breast cancers. There are drugs that can now block this pathway. And so in the box, you can see two of the drugs called ipatasertib and capivasertib, which are inhibitors of that molecule called AKT, which is sort of a key node in this pathway. And the thought is that by blocking this pathway, you will then block the cell's ability to grow and divide. And if this pathway is by error altered and activated without being tightly controlled, blocking this pathway can then serve to kill the cancer cell. You could imagine, because especially since I showed insulin as the example here, one of the side effects of blocking this pathway is it makes it harder for your body to regulate sugar. And so we actually see high sugar as one of the expected side effects with this drug, fairly easy to manage. And so there were two studies in the first-line metastatic triple-negative breast cancer setting, both combining Taxol with either capivasertib or ipatasertib. And both showed that in all comers, regardless of whether the PI3 kinase pathway was artificially activated, there was some hint of some response. But if you look on the bottom row across the two trials, in the population of patients, that 30% of patients that did have an alteration in that pathway, there were some encouraging responses. In one trial, the progression-free survival, the time it took for the cancer to grow, increased from about 4 months to 9 months, and in the other trial it was from about 5 months to 9 months. And so this was a good clue that these drugs may actually be helping in this selected population. And so that led to a phase 3 study called IMpassion130, which is a large phase 3 study with multiple cohorts, but cohort A was in triple-negative breast cancer, all of whom must have had an alteration in the PI3 kinase pathway, and they were randomized to receive Taxol alone with placebo or Taxol plus the ipatasertib. We are waiting for the results of this study. This study should finish accrual in November, and then hopefully by next year we'll have the first results. In addition, one of the most exciting papers to come out this spring, or presentations at the American Association of Cancer Research meeting, was a combination of the Taxol with the ipatasertib with immunotherapy, with atezolizumab, kind of bringing the beginning of the talk together with this. And what was seen is a response rate of over 70%. This was first-line triple-negative breast cancer, but even so, we would have expected somewhere on the order of a 30% or so response rate maybe. And so this was really quite encouraging that this combination was very active. And what was important and making it more exciting is it was regardless of the PD-L1 status, so that marker that I mentioned that had to be elevated to get the atezolizumab in the FDA approval, and it was regardless of the PI3 kinase alteration status. And so this is one of those combinations that seems to make immunotherapy work better by combining these two drugs. And so based on this phase 1 study, a phase 3 study is being launched as we speak, called the Opportunity-170, where patients will get randomized to the Taxol with atezolizumab with the ipatasertib or to some control arms. And this has the potential to be really exciting for triple-negative breast cancer. And so as we begin to close, hopefully I've been able to show you some positive results for triple-negative breast cancer with these new drugs, some of which have been approved, some we hope will be approved soon. And really, hopefully, we've turned a little bit of a negative into a positive here. And so we talked a little bit about immunotherapy-sensitive disease with the PD-L1, PD-1 inhibitors. We talked a little bit about the antibody drug conjugates hitting these other targets. We talked about the PI3 kinase pathway and these AKT inhibitors. And I did not talk about the rest of these, although I certainly would be happy to in the question and answer session. We didn't talk about PARP inhibitors for BRCA1-associated breast cancer, particularly triple-negative. We didn't talk about the use of platinum therapy for DNA damage or replication-stressed triple-negative breast cancer. There's EGF receptors and androgen receptors as well. And so in summary, I think triple-negative breast cancer still remains an unmet medical need, but we're in a transition period now where it traditionally has been defined as a catch-all for tumors lacking those three receptors, what it is not, and we're really starting to recognize different subtypes have different markers and different therapies, and we're starting to recognize the subtypes for what they have. Immunotherapy has clearly arrived now. We have a drug approved. We have a lot of other encouraging results. We have some encouraging results with vaccines. And we're beginning to look in the early stage now for prevention of recurrence in high-risk patients. Antibody drug conjugates are around the corner. They hopefully will be approved soon. And we have some very, very promising results with combination therapies. All that being said, we still have a lot more work to be done, but I think there's a lot of reason to be positive about triple-negative breast cancer now. And so I just want to acknowledge all of my colleagues and collaborators at Dana-Farber, Harvard Cancer Center, and Mass General. Particularly, I want to acknowledge Sarah Tolaney for sharing some of her slides. I absolutely want to thank all of the patients who've participated in all of these trials that I presented. We can't really make any progress in treating this disease without the brave participants who collaborate with us on these trials. I want to acknowledge and thank the Triple-Negative Breast Cancer Foundation, who I've had the pleasure of being associated with and working with for over 10 years now, and of course the Living Beyond Breast Cancer for putting together such a wonderful conference and providing such wonderful support to all the patients. So I'm happy to take questions, and thank you for your attention.
Thank you so much, Dr. Isakoff, for that excellent presentation. The first question actually touches on something that is of real concern to the triple-negative community, and that is recurrence. So the question is, if you have aggressive chemotherapy treatment, why would you still be at risk for recurrence?
So that's a great question, and it sort of gets to a fundamental or philosophical understanding that we always think about. So the first question patients ask me is, well, if I had surgery and you cut it all out, why do I need any chemotherapy anyway? And the answer is, almost by definition, what must be happening is there must be microscopic cells in a portion of patients that have already escaped and are hiding somewhere. The problem is our technology today is not smart enough to know who those patients are. And so the reason that we give people aggressive therapy is because we know, and in triple-negative patients, we know that it can be a higher fraction compared to, let's say, estrogen-positive patients, that even with smaller tumors, microscopic disease could have escaped. And so we give aggressive chemotherapy to try and go to the rest of the body so that even at the time of surgery, in case something escaped, we can try and kill it off. The problem is, the chemotherapy is not 100% effective. And so even in patients, in some of those patients, we will do a good job, and the chemotherapy will do what we hope it does and prevent it from coming back. And that's well known from randomized clinical studies showing with and without chemotherapy, there's significantly fewer recurrences with. But unfortunately, in some patients, even that aggressive therapy is not enough. And that's why we need some of these newer treatments, and why we hope that things like immunotherapy or vaccines might further kill off this, what we call microscopic or micrometastatic disease that we just can't know is there with the technology that we have. It's probably worth mentioning in that vein, there are new technologies that are being developed to try and pick out, well, after surgery or up front, who are the patients where we really do need to give more aggressive therapy. And some of those technologies are things that you may have heard called circulating tumor DNA. So we now have the ability in some patients with advanced disease to just in the blood identify pieces of DNA from a tumor compared to the host, and we can monitor that. And so there's a lot of research going on now to try and take patients with early stage disease who have finished their standard therapy and now look at their blood for circulating tumor DNA. And if you can find DNA there, then that almost tells you that there must be some microscopic cells hiding. That patient may be at very high risk for a future recurrence. That may be someone we want to give a lot more therapy to, or something new like immunotherapy. Not ready for prime time. We're not doing that in the clinic routinely, but that's the kind of technology that can see things that are, even beyond microscopic compared to what we can see on a CAT scan.
Thanks very much for addressing that question. Now you can hear me. Our next question is from someone asking if you received a platinum chemotherapy for early stage triple negative breast cancer and had a pathologic complete response, and then had the cancer return as a metastasis, can you receive a platinum again as part of your treatment?
That's a great question, and I don't know if that's a plan for my colleague, Dr. Silver, who spoke this morning. We had the pleasure of working together when he was at Dana-Farber many years ago on a trial looking at preoperative platinum. We were one of the first trials to do that. So the answer is generally yes. If you received platinum in the early stage as preoperative therapy and had a complete response, number one, the prognosis is very good if you had a complete response, but if you do have a recurrence, in general, I think it's still reasonable to consider platinum because although the patient may have had the tumor subsequently grow, suggesting the platinum didn't kill it off completely, if it did shrink to the platinum before and it didn't actually grow while you were receiving the platinum, then I think it is reasonable to offer that in the future. And in fact, many of our clinical trials with things like PARP inhibitors or platinum or other things will allow you to have had prior platinum as long as you didn't grow on it. But if you've had prior exposure, we do expect there to still be a reasonable response rate. So yes.
Thank you for that. This next question is about your last slide, immunotherapy for high-risk TNBC. Please define what you consider high risk, or what is considered high risk in TNBC.
Sure. So in that particular setting, the way we typically would define high risk, and everything is relative, obviously, but in the early stage setting, it's become, and in the interest of time, there are so many other things about triple negative I could have talked about. But just one thing I'll mention briefly is it has become now more routine or standard of care to receive preoperative therapy for early stage triple negative breast cancer if it's bigger than 1.5 to 2 centimeters. And the reason is based on that response, meaning based on whether the cancer is completely gone versus if there's any left, that will now potentially have some impact on what we do after. And so there was a study published a couple of years ago now called the CREATE-X study that showed that in patients who had residual disease after preoperative chemotherapy with triple negative breast cancer, getting 6 months of an oral chemotherapy called capecitabine, patients did better than if they did not receive that. And that, among other reasons, has really made the field now somewhat standard of care to give preoperative therapy. I showed in one slide earlier from my colleague Laura Spring, and there's a large meta-analysis from the FDA. We know that if you have a complete response to preoperative therapy, generally the prognosis is very good. Unfortunately, on the contrary, if you have residual disease and substantial residual disease, meaning the chemotherapy did not shrink that tumor very much, and then you have surgery, that's a population that unfortunately we know has a much higher risk of recurrence. And that is a population where we really would like to try and target things like immunotherapy. So in the setting of that slide, high risk was defined as residual disease after preoperative chemotherapy. Of course, if someone has a large, bulky disease to begin with and happens to have surgery first and then chemotherapy after, although that's becoming less common in 2019, if it's stage 3 then typically they should have preoperative therapy, but if it's a higher stage, we would consider that higher risk as well.
Thanks for addressing that question. Our next question is from someone who had a stage 1 triple-negative breast cancer and a BRCA mutation, and was curious about the use of PARP inhibitors. She's now completed treatment, and she's wondering, she asked for it, and obviously it was explained that this is not approved for early-stage breast cancer, and is wondering, is this something she might be able to access now that treatment is over?
So that specific question is being addressed in a clinical trial called the Olympiad study. And that's a study that's looking at patients who complete all of their therapy for BRCA1-associated triple-negative breast cancer to then receive either placebo or a PARP inhibitor, because the truth is we don't know the answer to that. And so outside of a clinical trial, I think in general we would not recommend that, but absolutely as part of a clinical trial, that would be worth looking at. And one thing about PARP inhibitors that we want to be careful with, in the advanced setting, it's one thing. We want to try and get response. We're trying to help people live a better quality of life and live longer. In the early stage setting, we have to be particularly sensitive about long-term toxicities. And there has always been a concern, not necessarily borne out with the data we have, but there has been a concern that based on the mechanism of action of PARP inhibitors, there may be a slight increased risk of leukemias. And so before we start prescribing this to everyone, we really need to do the clinical trials to answer the question, number 1, does it help? But equally importantly, number 2, are we not causing harm to these otherwise potentially curable patients? And so outside of a trial, I would be very cautious about doing that.
Thank you so much for that. The next question is, where and when can your subtype of TNBC be determined?
So it's not being done routinely for clinical practice, primarily because the molecular subtypes don't yet have actionable treatment interventions based on that. And so the Vanderbilt subtype that I showed you in one slide with the mesenchymal and luminal androgen receptor types, that really is not a commercial test at all now. The intrinsic subtypes actually can be obtained, but that test, the test is only available in Europe to get those particular results. The version in the US, first of all, it's only for estrogen-positive tumors. And second, in the US, that particular result of the subtype isn't included in the report. At least it wasn't the last time I had heard about it. But the most important issue is it's not clinically actionable yet. So my conclusion of the talk is that we have reason to be optimistic about the way we're moving in breast cancer, but we're not quite there yet to be using these molecular subtypes. So it's clearly of academic interest, but it's not something I would recommend trying to do routinely for triple-negative disease at the moment.
Thanks for addressing that. Our next question is from someone who's asking about the use of capecitabine or Xeloda after early-stage breast cancer treatment, and can it be used? What's the benefit?
So I touched on this a little bit in what I was just saying, so that question may have come in before I answer that. But the capecitabine, just to reiterate, based on that study, the CREATE-X study, if you received preoperative chemotherapy for your triple-negative breast cancer and had residual disease when you went to surgery, it is a reasonable approach now to offer the patient 6 months or eight 3-week cycles of the Xeloda. That study was done only in Japan and Korea and hasn't been replicated in the US. There are ongoing studies In particular, there's a study through the Eastern Cooperative Oncology Group randomizing patients to receive Xeloda or carboplatin to see if either is better than the other. But that's the setting right now that we would consider using the capecitabine in early stage triple-negative breast cancer.
Thank you for addressing that. Our next question is from someone who wants to know if there are statistics on women getting triple-negative breast cancer as a second primary, meaning not a recurrence, and how does that change your ability to take any of these new drugs?
So if I think I understand the question, it's in someone who's had a triple-negative breast cancer, let's say on the right side, and what their risk is in the future of developing just a brand new triple-negative on the left. So I'll first qualify by saying in the BRCA mutation population, we know that the risk of a second breast cancer is fairly high. It could be on the order of somewhere in the 40 to 60% range to have a second new unrelated primary. But outside of that, for the general population, if you don't carry a mutation, it's higher than the average population, but we generally quote somewhere in the about 0.5%, maybe as high as 1% per year of having just a new unrelated opposite side breast cancer. As far as we know, it's not different than other forms of breast cancer in terms of just because you had a triple negative on one side doesn't really, as far as we know, doesn't put you at risk for having a triple negative on the other side. And in fact, that second breast cancer, if someone is destined to develop it, could be hormone positive or HER2 positive as well. And I'm not sure the underlying point of the question, but it may be getting at, so should you be doing high-risk screening? And in general, we don't recommend high-risk screening to all patients who had a personal history of breast cancer, unless they're a BRCA mutation carrier or there's a strong family history. But the risk of a second new primary, in general, outside of those things, isn't considered high enough to recommend routine annual MRIs. There may be other reasons to do that if your medical team feels that you have dense breasts and difficult to see a mammogram, but for the risk of a new breast cancer alone, probably not.
Our next question is whether there's a lifetime limit on the amount of immunotherapy you can receive.
Great question. As far as we know, no. And there are people, we have somebody at our institution who was on the very first phase 1 study of atezolizumab. She is now on it. That study is long closed. There's a second trial to keep her on it. She's been on it, I want to say, for 6 years, maybe 5 or 6 years. As far as we know, with the antibody treatments, and this is true of Herceptin and pertuzumab too, there does not seem to be a limit, a lifetime limit. It's not like adriamycin. In my personal practice, I have people who've been on Herceptin for more than 10 years. The more challenging question is, does somebody need it? And what I mean by that is there are examples from the melanoma trials where patients received just a few doses of immunotherapy, had miraculous responses, but also had severe toxicity and had to stop the drug and never could receive immunotherapy again because of the toxicity, and actually stayed in durable remissions for years. And so while there's no lifetime limit to immunotherapy, because in a sense your body is a living drug, it's really unknown about whether you need to be on it for so long if you're doing well. Many people are afraid to stop it because if it's working and you're not having toxicity, why stop? But you may not actually need it.
Thank you so much for that. The next question is, who is a candidate for the cancer vaccine, or for a cancer vaccine?
So for the metastatic trial that we have, because of the way, I didn't go into too much detail about how the immune system works, specifically presenting the peptides to the T cells, but there's molecules called the major histocompatibility complex molecules, and the vaccine that we're using, that peptide vaccine, only works with what's called HLA-A2. That's found in about 50% of the population. So that trial is open to anyone who has metastatic triple-negative breast cancer. And regardless of line of therapy or how many therapies you've had, but you do have to have HLA-A2 positive. And that's, If you know anybody who's had a bone marrow transplant, those are the kinds of things we look at when we talk about matching. And so we actually test for that, and about half the patients have that. For the early stage study, if you had a cancer that was, I think the limit was 1.5 centimeters, and you received chemotherapy, and you are beyond 90 days from finishing your radiation, but less than 1 year, you are eligible for that folate receptor vaccine. And that's open at several sites around the country. We have it in Boston. It's open at the Mayo Clinic and some of their sites. I'm not sure where else in the Mid-Atlantic, but you'd be a candidate for that trial.
Our next question is it true that recurrence in triple-negative breast cancer dramatically decreases after 3 or 5 years, and what do we know about outcomes?
So generally, I would say yes. The peak of incidence of recurrence is usually in that first 1 to 3 year period. The incidence decreases when you get to about 5 years and kind of levels off, and it's I've had 1 or 2 patients who recurred just after that, but really after 6 or 7 years, I think the recurrence curve is pretty flat. And so we used to say, this was sort of our version of lung cancer. It was sort of, it's an aggressive kind of cancer such that if it's going to come back, it tends to come back early. We never make 100% guarantees. I wish we could, but we always tell our patients, the likelihood of recurrence after 5 years with this type of breast cancer is very low, but it's not a guarantee. And that's very different than ER-positive breast cancer, where the risk of recurrence does go on for decades, really. And my personal longest patient actually had a 33-year interval between her primary breast cancer in 1977, and it came back in 2010, which is 33 years. But triple negative, we generally don't see that.
Thank you. This is a good question. Are you aware of any extra measures taken to attract African American women to participate in TNBC clinical trials?
Well, I would throw this back at Haley. I think organizations like the Triple Negative Breast Cancer Foundation actually, this is a key piece of their mission, is to try and make these trials both known to and accessible to. And so I think that's important. We have a very close working relationship in our institution with Boston Medical Center, which tends to have a higher population, a higher African American population. And it's actually been a priority mission of our hospital to collaborate with them, and as well as my colleagues at Dana-Farber. And so we have a very open line of communication with the medical oncologists there, email us all the time and try and refer patients in who may not have access to trials locally. We are involved in some outreach programs, and I think many institutions around the country, it's a priority to try and do that as well. Not specifically for triple negative, but I'm proud to say that in our phase 1 program at Mass General, we just hired a nurse practitioner whose specific role is to help with encouraging a more diverse population in our trials. And so she's become the liaison for anybody really of any underrepresented population who wants to come to Mass General. She's our liaison to sort of facilitate that coming in. And I think more centers are beginning to do that. So, but it's clearly one of the most important needs and missions, I think, for all of our cancer centers.
Thanks so much. So I'm going to ask the last question, unfortunately. You guys have really wonderful questions. I'm sorry we couldn't get to all of them. Do we know what causes triple-negative breast cancer? What fuels the growth?
I mean, you ended on the billion-dollar question. Except for these small percent, about the 10% or so, or maybe 15% that are BRCA1 associated, in general, the answer is we don't. We don't know why it tends to affect younger women disproportionately. We don't know why it tends to affect African American or Hispanic populations more. There are theories and people are looking, but the truth is we really don't know why. What we do think is, although it's called basal-like breast cancer, we don't think that it originates from the basal cell, and I didn't show the anatomy and architecture of the breast, but we think that it has essentially the same cell of origin, one of the what's called luminal cells of the breast. We think it probably does have the same cell of origin, But why it loses its receptors or becomes triple negative, that we don't know. But if anyone has the answer, that's a billion-dollar question.
Well, thank you so much, Dr. Isakoff, and on behalf of Haley and myself, we really want to thank you. Let's give him a hand, everyone. Thank you so much. And so at this time, we're going to say goodbye to our live stream guests and just remind you, if you'd like to come back and be with us at 2:15, our next session that will be web streamed is on sex and intimacy, so we hope you'll join us. And for those of you in the room, just to let you know that box lunch is now available in the foyer to be picked up and enjoyed in the ballroom, and you can visit with our exhibitors.